Good evening, everybody. My name is Jenny Pearson. I'm an Education Officer for the Primary Health Network. Thank you all for joining us tonight. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on and pay respect to elders past, present and emerging. Tonight is our community management of COVID-19 in the Hunter and New England. We have a great array of speakers for you tonight. Our first speaker is Dr. Mark Lowenthal. He's the Director of Immunology and Infectious Diseases at Hunter New England Health. So take it away, Mark.
Thank you very much. I'll give you a brief outline of what actually happens at the moment, and it's really in a state of flux, so it might be different in a little while. But currently, anybody who tests positive for COVID-19 with a postcode in the Hunter comes up on a journey board, a flow sheet, and is sort of automatically referred to public health. At some stage, they're captured by us at the health service, either from the flow sheet or from public health, and they are contacted by telephone. There are really too many people for us to visit. I'm actually now based at the hospital in the home program, the same place that ran ordinary hospital in the home, but really we don't go out to visit the COVID people on the whole, because there are just too many at the moment. We've got a series of questionnaires that can be administered either by telephone or video link, and we can organise to drop a pulse oximeter out to everybody, or to most people, and we're about to introduce a risk stratification so that some people will be called for longer and more often than others. And in the meantime, at the hospital itself, there's both the infectious diseases team, my old team, and the respiratory team. And we actually share a ward, and that ward is the COVID red ward. There's a COVID orange ward for people who are possibly positive for coming to hospital, either because they have suspected COVID or because something else has happened to them and they have symptoms or epidemiologic risk factors for COVID. I'm a little bit embarrassed to say that when people arrive now, we don't automatically notify their GP, but hopefully we'll start doing that. And we really, they're all asked for a GP. So really they have to have a GP either on a system somewhere or name their GP for us to know who their GP is. And our role in hospital at home is actually principally to monitor them. And if people are getting sick, they can be referred to the hospital. They can either be referred straight to the emergency department, but most people actually avoid the emergency department and go down to the ward and are seen directly by the COVID team. From there, they can either go home or they stay there and are treated. And there's also an ICU team. We also now run 2 hotels. We've become hotel managers, and we have 2 hotels for positive patients, and there is accommodation for close contacts. And really, to get into any of those, you have to be in one of 2 situations. Firstly, people who are positive in a household of negatives can be put in the positive hotel, and then there's people who don't have suitable accommodation to go to for one reason or another, they may be homeless, they may live in a unsatisfactory situation where they're in an area with lots of people, and can potentially cause a large localized outbreak, or they're suffering from mental illness, have drug and alcohol issues, and we have a group of people who have been caught by the police. So once they're notified onto the portal, and they go onto the public health database, that automatically goes to the police as well. So the police have a list of people who are listed as being COVID positive. So we monitor people, we look after them, we can organise varying degrees of efficiency, support, drug and alcohol, isolation support, mental health support, and in some cases, food and clothing where necessary. If people are getting sicker, we can organise them to go to John Hunter Hospital. There is an orange and red ward at the Mater Hospital as well. So for people who have mental health issues that would otherwise have got them to Mater Mental Health can go there. And if everything goes well, we also organise for the clearances, medical clearance notifications that go both to the person themselves, which they find very useful, and to public health to take them off that database. And we hope, and I guess Joel talked to this as well, we really can't produce a typical discharge summary for everyone because there are really too many people, but we have a brief summary based on their COVID symptoms to clear people, and we can talk about the discussion that you don't, but we generally don't need further a negative swab, and we actually try to avoid that when it comes to clearing people. There are set criteria we use, and they get a clearance form, an information sheet, which says that they can't become a close contact for 6 months, or effectively treated as immune for 6 months, and says that we recommend they don't get a swab because there's a chance it will come back positive for fragments of RNA and cause anxiety to everyone, and they don't need to participate in the screening programs for that time. So we look after all of that, and hopefully we'll have a system so that if the person has a GP, they can receive that information and just get an idea of what's happened to that person. There's also a direct role for the GPs, and we have lucky enough to have a number of GPs working with us, and that's just going to start in earnest on Monday, although they have been doing a great deal for us already, but I'll leave Joe to talk about that. So that's probably enough for me, I think. I'm sure there'll be questions, but that outlines hopefully what we do, both at what we call COVID care in the community and how people get to hospital and then get back out again. If that's okay.
Yes, that's fine. Thank you very much. Our next presentation is from Dr. Sharon Ryan, who's a Senior Staff Specialist for the Paediatric Palliative Care Service and a Director of Medical Services at John Hunter Children's Hospital. And presenting with Sharon is Kathy Graham, who's the Nurse Manager, Paediatric Ambulatory Care at John Hunter Children's Hospital. So if you ladies could just turn your cameras on, and I will make you a presenter, Sharon.
Excellent, thank you.
I just wanted to fade in for everybody.
Hello everyone, it's wonderful to have an opportunity to be talking with you, and Kathy and I, we don't have a huge number of slides, so please don't have a heart sink at the prospect of slides. But we, I guess I just want to say, look, I'm not doing this in my capacity as a palliative care staff specialist. I'm doing this, my involvement with HEF is really in my role as Director of Medical Services. So I just want to do a really quick timeline, which is, I suppose, many of you are probably very aware of this, but just the speed with which things ramped up for us here in Newcastle. And then there was a little bit of a lull, and now we are in a state of, I suppose, the anticipated wave of patients is upon us. So the first case that we actually had here in Newcastle of any type was the 28th of the 7th, and we always assumed that there would be a 2 or 3 week period before we would have hospital admissions, but the way that it panned out was within a few days we had to admit some pediatric patients. Then we all went into lockdown. We had to activate our so as Mark referred to, we designate the ward spaces which are for COVID positive patients as being red spaces, and the ones which are waiting for determination of COVID status as orange. So we had to activate our red space. And then a few days later, Kathy and I started, and it dawned on us probably a tiny bit slowly, that the actual work of the pandemic here, certainly in relation to pediatrics, but I would say Mark would agree, in adults, is actually the HEF service. So it's a community-based service. And on our first day of being set up, we had 13 patients admitted to our service, and we also realised that there was a big demand for in-home swabbing of pediatric patients, so we needed to set up the swab squad, and we were able to get, we're so fortunate to have had already on as a general paediatrician someone who's also trained in paediatric infectious diseases, and Cohen joined us and helped out. So can you, oh sorry, do you want me to stop?
Before you go any further, can I just get you to do one little thing? If you can just go to display settings, which is just above your slide there.
Oh, yes.
And just click on that, and then swap presenter view and slideshow.
Oh, okay.
Beautiful. Thank you.
Excellent. So, and look, Mark was being very modest in terms of like saying that his service was busy. You know, our numbers are actually about a third of what Mark has been handling in the adult side. But so just to say that at the moment, up to this point, we've had 236 pediatric patients. We had 65 on the 9th of September, and now in the 29th of September we have 236. So you can see we're going through a massive surge at the moment, and currently active on our books we have 138. There was at the beginning, we had a number of admissions for psychosocial concerns or need to provide a safe place for isolation of young children, but we haven't had to do that recently, and we're just pointing out that we've actually had an awful lot of swabbing that our swab team has done, and in the space of time since they were set up, they've done 2,000 kilometres travelling around backwards and forwards across, you know, as far away as Port Stephens and sort of out to Curry and such like. Now, this is a little bit out of date, and Kath is going to talk to it, but not the detail, just I guess what we have had to set up in terms of staffing. Over to you, Kath.
Hi. So this is the model that we started back in June, and it's changed significantly since then. But we've got Sharon as our sort of executive lead for the service, and she works Monday to Friday. She helps with clearance certificates and answers any questions that we need most days. And we've got our paediatric infectious diseases specialist, Cohen, which Sharon was referring to earlier, who is 2 days a week. He's doing a lot more than 2 days a week at the moment, but he's certainly providing the clinical expertise, treatment plans, doing telehealth appointments with children and their parents, depending on the need, and also doing patient clearance certificates. He also holds the phone after hours, as does Sharon, for patient calls. So we do have a dedicated HEF phone for paediatrics for COVID, and that phone is answered 24/7. So after hours, it's Sharon, myself and Cohen that will answer that phone after 5 o'clock. We have a lot of registered nurses plus scientists plus allied health or anyone that can help do phone calls at the moment. We did displace our sleep service for the COVID red zone, and we are using all of those staff within the COVID HIT service, the COVID Kids at Home service. We did have originally 2.6 FTE. In the last week, that's grown to probably around 7 or 8 FTE. We're probably moving in the next week to increase that to 10 FTE just to get through calls. So as we've got 138 patients on our books, and the majority of those need daily calls. We're trying to risk stratify those calls to hopefully second or third daily, but we happen to have a really complex cohort of patients that have huge psychosocial needs at the moment, which is leading us to need to do a whole lot of daily calls at the minute. As Sharon said, we have a swabbing team where we've got 2 cars and 2 swabbers. We always do swabbing in pairs so they can check each other's PPE, and that they have safety concerns in some of the facilities that they're entering at the moment, needing police escorts to enter some of the buildings and houses that they need to go to. They're doing up to 35 to 40 swabs a day in up to 11 or 12 different locations in the one day. And that is usually for people that are positive in the house, but the children are negative, so they can't go to any swabbing locations, or they just don't have a car or transport to get out. We soon realised that we needed social work. We started off with 0.4 social work, but now I have social work every day, 7 days a week, for the huge psychosocial need that's required for our cohort. And I have one admin person that's helping with admissions and discharges. So that's a really brief summary of our staffing model at the moment. We're going through surge plans at the moment to look at escalating to probably even a much bigger model than what we have at the moment. So we're sort of actively trying to pull people from areas that are less busy to help us out do some of these phone calls. That's me, Sharon.
Thanks, Kath. I see that there's a question about what happens regionally, and I think Mark is the same. So far, our HIT services are centralised here, and we provide support for the whole of Hunter New England. Having said that, we will on occasions need sort of the people on the ground close to where the patients are to be involved in drop-offs of equipment or such like, and so it's a sort of collaborative model with across the LHD, but we also have offered support to from an admission point of view to the Central Coast LHD, and also to the Mid-North Coast and Northern New South Wales LHDs, as well as they're setting up their services. Now I'm just going to move on to the we'll skip over that one. Oh, sorry, this is just our risk stratification, which is actually the same as what is in the ACI framework, which there's one for adults and one for children, and it's actually in the pathway that's going to be launched that you will see. You'll be able to access that and see that. But what I actually wanted to do was speak to this little case presentation, just to give you a little bit of a sense of the types of patients that we receive. So this is one of our cases. She's a 14-year-old girl from Western. I've just done a little clip from the referral that we got from Public Health. So the thing about her was that she lived in a accommodation where there were 9 other people, including children, with 1 bathroom. And then there's looking a little bit further into this girl, there's multi-agency involvement, including mental health services and active involvement with DCJ, which is what FACS used to be. It used to be FACS, and she had significant mental health issues previously, and so as soon as we saw this referral, the main question both for Public Health and for us is, where could she isolate and who will isolate with her? She's 14, she can't be left on her own, she can't be put in a hotel on her own. And then who is a safe person for her to isolate with, and what would that mean for them after being in close contact with a positive person? We had to liaise with the DCJ around who has parental responsibility, contact mental health for support for her during her isolation, and also think about the likely things which would make her stay in isolation much more difficult, including not being able to smoke if she was a smoker, whether she was using any other recreational drugs, did she have access to devices, think about whether she's pregnant. There's a whole sort of raft of things for somebody who has such significant disadvantage. She hasn't had any major medical issues, but she did have a panic attack. That was her first panic attack, and the carer that was with her needed to call an ambulance for that. And then I suppose the other thing that we are very mindful of is, we, and Mark will attest to this, I'm sure, as well, is that this virus has uncovered an enormous amount of social disadvantage and incredibly distressing situations that people live in, and we are there, we discover these things, and then at the end of this time we sort of go, okay, discharge, that's the end of goodbye, and we can't take on fixing all the problems that we've discovered, but there is a duty of care in relation to people's safety as well. So what happens to this girl when she is discharged out of her DCJ supplied and supported care back to her former unsafe environment? So that was, I think Marika and everyone wanted us to just provide a little bit of a case study just to sort of give you a bit of a sense of the story. So I won't labour too much about the actual case, but just, I mean, as Kathy said, the sort of social work component, that the psychosocial distress and care of these paediatric patients is probably the biggest part of our work. Medically, it's not been challenging so far at all. And in fact, obviously the adults in the households are the ones that are much more at risk of getting sick than the children, and that in itself is a sort of challenging process. And some of you may be aware from down in Sydney that there was a lot of talk about this home and the hospital model, where unaccompanied kids needed to be admitted to hospital because their carers are either dead or in intensive care. It looks like as vaccination rates have gone up, that the public health unit has been more and more successful in finding people who are prepared to look after kids, and we haven't had anywhere near the demand for that home and the hospital type model as we expected to. But what we have had is a massive increase in the number of patients just in the last few days. And we're very concerned, as we were sort of talking about just before coming on to this broadcast, about the effect of this friends bubble and what that might mean in terms of paediatric cases. And I think we might call that quits there. Kath, is there anything else you wanted to add?
No, I think that covered it. I think we're really clear when we do our intake that we have a plan if the parents were to be admitted unwell, who they would like their children to go to, and having a really clear plan that we're not trying to do on the day, because sometimes the adults get sick really quickly and are shipped off in an ambulance, and we have to have a plan for where the kids, whether there's a double vaccinated relative if they're a single parent, or where else they can go to. Is there grandparents that are double vaccinated that we can put the kids with, because that is definitely a real issue.
Thank you.
Thanks very much, ladies. That was really good. Jo, are you there? Our next presenter is Dr. Jo Wood. Jo is a GP and the Clinical Director of Hunter Primary Care. Did you have a presentation?
I do, yes.
Okay, I'll just make you the presenter.
You see my screen all right?
Yes, we can.
Okay, so if I go to that, is that doing the right thing?
If you just go to display settings and flick it over. Yep, the swap presenter. Yep, beautiful.
Wonderful. Okay. Good evening, everyone. Thanks for having me. I think I got upgraded there, but you know, I'll take it. I am a GP currently also working in the COVID care in the community team as of the last couple of weeks, which has been very exciting. My slides here are actually representative of another hat that I've been wearing, which is with Community Health Pathways as one of the clinical editors. Sandra is going to talk to our pathways in a minute, but they're quite integrated, so I find them difficult to separate. I also have a 3-year-old that's just come to join me. My apologies. All right, so to start it off, we'll just go to this, my constant plug, the Health Pathways. There's the username and password there for anyone that doesn't know what they are yet. This very brief presentation, my objectives would be to describe the current pathway for the COVID positive patients in our region, which we've already sort of gone through, but also just to talk about the new GP VMO position that's there. Just give some ideas around the potential for sharing or handing over care to general practice going forward. Go through some of the key assessment points that the teams are doing when they're looking at their COVID positive patients, and also the red flags that can trigger escalation, just to give us all some thoughts around actually caring for people with COVID-19 in the community. Just the key management points for managing mild COVID-19, which I think actually Sharon's really touched on already. Where to find those the resources on Health Pathway, and how we sort of anticipate that general practitioners and how they actually already have been contacted by their patients in terms of how to direct them to where their care will be coming from. There's been a few GPs that have had their patients reach out saying, haven't heard from anybody yet. So we've got some details on Health Pathways on how to help them with that. Also, just to describe some of the preparation points that GPs might like to consider when they're looking after COVID-19 patients, you know, preparing themselves for that in the future. So we've already talked a little bit about the numbers currently. There was 55 new ones today, so that total outbreak of up to 837. The active cases, according to Facebook, was 524, and we've heard from Sharon that 138 of those were paediatric, and there's lots of people in close isolation at the moment, which I think is really relevant for general practice because they're stuck at home, but they may need their normal care needs met, and we can, as GPs, still care for those patients. I just put this in here because it's just an interesting reflection on the distribution of ages across our region that are getting infected by COVID-19. And, you know, I think that the demographic is a lot different to the outbreak that was around last year. And certainly, like we've become involved with COVID care in the home, thinking that, you know, general practice care would be great if we could get that sorted out somehow. But the demographic doesn't seem to, like, there's certainly a lot of people that don't actually have regular GPs. So, and that level of care and sort of social intervention that Sharon was describing is, you know, reflective, I think, of a lot of the cases that are, a lot of the people that have got COVID-19 at the moment. I've just stolen this from Dr. Lee Fong, who's been producing this for our local GP group, just showing that sharp rise. And I sort of was having a little bit of a play with the numbers just in September for us, and we're having that sharp rise just in September here for us. Just to sort of think about and talk about the ways that GPs may be involved into the future. At the moment, we've got 2 GPs a day starting from Monday, which is fantastic. And they'll very much, I'll sort of go through how they're integrating with the team at the moment. But we're really hopeful that maybe we might be able to get some parallel care started, which is, you know, happening in other health regions across New South Wales. So the one that I know about that's working is in Western New South Wales, and their patients that are in COVID care in the home are classified as outpatients. So the GPs are able to bill the MBS and offer their routine care or, you know, consult with them while they're under the care of their COVID care in the community team. Unfortunately, locally for us, the way COVID care in the home is structured is that patients come in as inpatients, which means that we're restricted as GPs from using the MBS really for anything related to their admission reason, which is COVID. You know, technically we can still bill for completely unrelated care, which is very difficult to define, I think, when you I'll go through some cases in a tick, but if you have a person that's reaching out to their GP for their usual antihypertensive medications, as happened with me, for a person that had a headache and hadn't been taking his normal antihypertensive medications and thought maybe that might be why. So there's, I don't know how you can separate those two things and say that it's not related to COVID, because, clearly they're sort of integrated somehow. But there may be instances where you could clearly say this is unrelated to their COVID presentation and could be billed safely. Ultimately, we'd love to get some GP shared care model happening. I think there needs to be there's lots of sort of systems issues that go into that would need to be sort of ironed out, but definitely, it would be fabulous for care going forward as well, just to get those sort of interaction between primary care and tertiary care happening. And then, again, there's the option, of course, of just having patients go directly to GPs, which hasn't happened in New South Wales anywhere that I'm aware of, and in Victoria they have a model, but I'm actually not quite sure of the the on the ground experience with that. It was certainly what we were planning for last year when we had the outbreak, but there's just lots of sort of systems issues to try and sort out to try and get that to happen. But definitely all part of the thoughts and plans. So in the COVID care in the community team, there's sort of a lovely flow of care that goes on for patients as they are being looked after by the team. It's very nurse-led, which is great. So that sort of means that the clinical support they get from the doctors in the team is very much about what sort of gets escalated up to them. So that initial assessment works out, the destination for the patient. There will be some consideration for medications, and at that point in time, I haven't come across anybody yet, but I think there's some questions in the chat around sotrivimab, which is definitely not my area of expertise, but there is some clear guidelines in the National Task Force have put together that sort of select out the kind of patients that would be eligible for that. It's the kind of thing that I imagine that as GPs, if we knew about particular patients of ours that were COVID positive, we might want to flag that. There's a daily review that everyone's sort of outlined already. I'll show you some of the questions that are in that and where you can find them in the health pathway as well, just for your interest. Each of those those daily assessments is looking for some red flags, which are nice and clearly outlined in the health pathway as well. Then the discharge process, which has turned out to be the most time-consuming part of the job, is very much about just going through the SONG criteria. I'll show you the dot points for that, which are fairly straightforward, but just making sure that all the stars align, that the person is actually eligible to be de-isolated, which then gets sent back to public health and is the point that Mark was talking about in terms of, that isolation certificate, de-isolation certificate, sorry, that gets sent to the patient. You can go to GPs and it just gives that nice, clear understanding that they're no longer infectious and you can now look after your patient again. So this is just that sotrivimab criteria that I was talking about before. So it's got to be started within 5 days of symptom onset. They can't have had any vaccinations. They can't have any oxygen requirements. So people at home, and then these are the risk factors that we're looking out for: diabetes, BMI greater than 30, chronic kidney disease, congestive heart failure, COPD, and age more than 55. Then, so I was just talking about the initial assessment and the daily assessment that the nurses are doing. So this is just a snip of the entire page, but if you were curious and wanted to have a look at it, if you go to our COVID positive pathway for adults, it's in one of the assessment points and you can have a look at it. And I might even ask Michelle what she might do with this sort of information in terms of preparing your own practice for when perhaps you may be looking after COVID positive patients in the future. And that's the daily assessment one. So these are the red flags that we were talking about. So when the RNs are doing their calls, they're looking for these sorts of red flags that would require escalation for hospital care. So desaturating, we'll develop some techniques to try and pick up some hypoxia, people walking around or talking at the same time with their SATS monitor on their finger, see if they're desaturating. Tachypnea, which was mostly observed from conversation, but can be counted. These are subjective experiences of chest pain, again, subjective experience of postural hypertension. Tachycardia can be measured on your SATS monitor, and then, clearly if someone's not oriented to place, they've got any coughing up any blood, it's a bad sign, or signs of rhabdomyolysis. And then vomiting and abdominal pain and diarrhea are actually more of a feature than, when we were initially learning about COVID-19, and so signs of dehydration. So the referrals for unwell patients is, as my understanding of how it's happening with the COVID care and the community team, that it's, if it has to be by ambulance, then that's fine. They can call an ambulance if they're unstable, but if there may be some possibility of arranging patient transport otherwise, and certainly if they need ED assessment, then goes by ED, but wherever possible, it's by direct admission to the ward. So again, when we get to the point of having GPs caring for patients in the community, we'll have all of these escalation pathways worked out nice and clearly so that it's, very straightforward in the community as well. One of the, I mentioned before that there's been some GPs that have had patients reach out, not quite sure what to do. So we've just, in the pathway, we've outlined what the current plan is with COVID care in the community looking after patients, but that if, you're stuck and you're talking to a patient and you just want to know if maybe you could escalate that a little bit, then there's some phone numbers for the GPs to use. One of them goes straight to the doctors, the GPs that will be sitting in the office with the COVID care and the community team. And then there's also the RNs that are working at the Medi Hotel and for those being cared for at home. These are the release for isolation criteria that I thought you, as GPs, would be interested in knowing about. So there's those that are people that have remained asymptomatic, so they can be released day 14 since their first specimen was positive, provided they haven't had any symptoms. Those that have had symptoms, they can be released at day 14, provided they've had their symptoms resolve within 72 hours, and that's from the onset of symptoms. And then there are those that may have some persistent respiratory symptoms that linger a little bit longer, and as long as they get to the 20-day mark and they're not significantly immunocompromised, they too can be no longer considered infectious and can be released from isolation. So if GPs aren't being referred patients with COVID-19 right now, what is it that we could do to prepare? I think there's lots of discussion in various GP forums around Australia and in New South Wales in particular. There's constant hope that we may get some kind of care monitoring option, something like Care Monitor, for example, that would work well in general practice and also work well with our hospital systems. Something that GP practices could have a look at now and see if it's something that would be appealing to them anyway. It just gives the option of monitoring large numbers of people at a time. Then there's being familiar with the COVID positive pathways that we do have now. So if you're familiar with the content of that and you know where to go, then as our models for looking after COVID positive patients change, you'll know where to go and where to look for that information. There are some guidelines by the National Task Force that I've alluded to, and I think I've put into the chat actually, that outline the management, and definitely worth getting this for community management, and definitely worth being familiar with them. I think really the critical thing for general practice right now is the amazing work that they're doing with vaccinations, because that will definitely alter the trajectory of how we care for most of our COVID positive patients if we can get our population vaccinated. I think we can keep working on our video conferencing skills, because we can get a lot of information over video consults from our patients when we're examining that way. I think we probably need to become really familiar, or, start learning about how to look after people with post-COVID symptoms. And I think that the other critical part that general practice really does all the time and is probably under acknowledged is the work they do to keep people out of hospital as it is. You know, tertiary services are under the pump and will be even more under the pump. So any work that general practice can do to keep patients well and at home is going to be very critical for our tertiary services survival. I know we have, you know, many curveballs this pandemic, and one of the current ones is chest pain presentations post Pfizer vaccination. And I think there's been a lot of presentations to the emergency departments with that. So, you know, building our capacity to manage chest pains in the community that are, you know, that can be differentiated safely. So doing some acute assessments of chest pain and trying to rule out pericarditis where we can for those Pfizer reactions that are being seen. And I think another important thing is just staying connected and keeping your ear to the ground. So there's lots of great ways for GPs to connect these days, and certainly if you've got a local GP group that you can connect with, I would highly recommend it. There's some forums on social media. If you would like to know more about them, please reach out. I'd be very happy to connect you. Anyway, it's been a pleasure. Thank you. Jenny, over to you.
Thanks very much, Jo. Our next presenter is Sandra Fitzgerald. Sandra is a pharmacist and a Health Pathways clinical editor.
Can you see me?
Yes, I can.
And can you just make me the presenter? Show my screen. Which screen can you see?
I can see connected to go to webinar.
That's not the screen I want. How do I change screen?
Do you have a screen with a little arrow next to it?
Where would I see that?
I'm not sure because you're saying something different to me. You could slide your presentation over to this
okay,
screen.
let me try that. Right. Okay, sorry everybody. I was all set up on the wrong screen. Oh, anyway, I was just so can you see the health pathways there?
No.
What can you see now?
I can still see connected to go to webinar. Now I can see it.
Okay,
now
right.
now I can see a document.
Oh goodness me, that's no. Okay, I'll pull this over here and then you should be able to see. Can you see now?
Yes, I can see now.
Okay, apologies everybody. I was going to try and show you the Health Pathways login, but Jo did show that, so hopefully you all are very familiar with Health Pathways and know how to log in. And we've had some very exciting developments today. We've had a clean-up of our COVID-19 pathways. So for those of you who are familiar with them, you would have normally gone into the COVID-19 section and you would have seen an initial assessment and management pathway, which we developed right back at the beginning of the pandemic, which was around assessing patients who needed to be tested and working through all those issues. And we also had an ongoing assessment and management pathway, which was for COVID positive patients. And then we had an assessment and management in children pathway. And so you won't find those pathways anymore. Instead, when you go into assessment and management now, you'll see this first one, which is respiratory presentations during COVID-19, and that went live about an hour ago. And so that's just about assessing patients who have respiratory symptoms, you know, in this new era of COVID. And then we've got the care of the COVID positive patients, and we've got the paediatric pathway and the adult pathway that have been written collaboratively by Mark Lowenthal for the adult one and Sharon and Kath for the paediatric one, along with Jo and I. So just quickly showing you the respiratory presentations during COVID-19. And over here in the key links, we link through to the living guidelines that Jo has alluded to, and also the RACGP guidelines managing patients with who present with respiratory symptoms. And then we just go through all the usual red flags. And then the assessment is just as normal. We go through some ideas about how to prepare areas in your surgery to isolate and consult patients, all the infection prevention and control things, how to do an initial screen, preferably by telehealth, but if you have to do it in person, some ideas there. And then how to go about arranging their testing and so forth. Joe was talking about getting really good at telehealth. If you wanted some ideas around that, we've got here how to do a remote examination via telehealth and checking respiratory status and so forth. And we've got some really good links down here, for example, from the Agency for Clinical Innovation about how to do a virtual respiratory assessment. And then management is just, it's fairly simple because, you know, it will depend upon what you see. And then looking at the care of COVID positive adult patients, again, over here, we've got the key links that people have talked about. We've got the ACI guideline that Mark talked about and the living guideline, which is looking after patients with mild COVID-19. In the clinical editor's note, we've talked about the billing situation with patients being inpatients of hospital in the home. Again, we've got the red flags. In the background, we talk about what the community in care in the community, COVID care in the community service is about, which Mark has been describing, and we've put all the contact numbers for you there, so to get through to the GPs like Joe and to get through the nurses 24 hours a day. I'm just going to shut this for a minute so we can see a bit more. And just so this is, as Mark has explained, you know, the care will be done by COVID care in the community, but if the patient happens to ring you, this outlines very clearly what the sort of care they'll be getting. And as we move on, if GPs need to become more and more involved in that care, we've outlined the sort of steps that that the COVID care in the community team follow. We've suggested that patients prepare for a call from contact tracers and the sorts of things they might like to think about. And then under management, if you were looking for some information around Citrubimab, that's here under Management 5 in disease-modifying treatment. And if you click through the links there, that will give you the living guidelines information around that, the National Clinical Task Force. And just down here, just a few key features in Management 8, we've got the New South Wales Health Release and Recovery information, which goes through what Sharon and Mark were talking about around clearance from isolation and what that medical clearance certificate will give you. And then finishes off with watching out for the long COVID symptoms. And then just and the contact details for the COVID care in the community team are scattered throughout the pathway, and you'll find them wherever you see that drop-down box. And then again, with the positive paediatric patients, it follows the same sort of format. We've got the ACI Caring for Children with COVID in the Community Guideline and the Living Task Force Guidelines. All the red flags as normal, of course, about the COVID Kids at Home service and their contact details, so you can find them readily. And I think they were the key features I wanted to point out. And the only other thing I wanted to tell you was, if you've got any feedback about this at all, please send feedback by the send feedback button. If there's something you'd like clarified, if there's something you don't think is quite correct, if there's something you would like to have added, we really do value your feedback, and we do use it to make the pathways better and more usable and more useful for you. And I think that's from me. Thanks, Jenny.
Thanks very much, Sandra. Joe, if you're there, we might do the questions now. Oh, actually, just before we do that, Michelle Redford is just going to jump on and provide a quick summary.
Hi, thanks, Jenny. So I just wanted to be really clear that right now in the region served by H&E Health, that the role for GPs in managing acute patients with COVID is none, just to be clear. So that when a patient's diagnosed with COVID, their care gets taken over by HIF, and so there's a tiny window potentially in between their diagnosis of COVID and then being admitted to, COVID care in the community rather than HIF, when the GP might be involved. But that should only be a very short window. And then they're under COVID care in the community or the paediatric service until they are discharged, de-isolated, and then the GP is involved again. And so in terms of the acute management of COVID right now, GPs are not directly involved. The ways that they could potentially become involved would be if the patient contacted them for something that was kind of intercurrent. And as Joe says, it's very difficult to completely separate out presentations as being definitely COVID related versus completely unrelated to COVID, but I suppose there could be a situation where it was completely unrelated to COVID, and in that circumstance, GPs can bill according to their usual billing practices, including Medicare. But if it's a COVID related problem, then they cannot. And so in that situation, Joe, my understanding is that then really the GP can either provide that care without any billing, or privately bill, or direct the patient back to the team at COVID Care in the community. Is that, can I just clarify that for the audience? Is that okay?
That is the current situation. So unless we can get the inpatient outpatient status flipped so that they're outpatients, and then that would actually free us up to be able to do some of that concurrent care, which is what they're doing in Western New South Wales. So fingers crossed.
Yeah, so that might be something for the future, but right now we're not really managing these patients. And so GPs on the ground just need to kind of understand the contact system, which is all there on Health Pathways, which is awesome, and have an understanding of what's happening to your patient whilst you're kind of not involved directly, and then be there at the end, you know, to deal with other things. I suppose the two things that struck me about that are that we do need to be able to recognise this PIMS TS thing with children, because that happens normally after they've been de-isolated. I know it's rare, but I think that is something that GPs could like look up. It is on Health Pathways. But I think that's potentially something that we do need to be alert to. And of course, as people have mentioned, long COVID. So I think, you know, that what do you do when someone's been discharged is important. The other part of that is vaccination, because some of these people might be halfway through a vaccination schedule. And so again, that is on Health Pathways, but if you've already had one dose and then you catch COVID, then you have to postpone your second dose if it's Pfizer by at least 8 weeks after you've recovered, and Astra if 12 weeks after you've recovered. So these are the sorts of little practical things that GPs might have to get involved with. That was just to clarify.
Thank you. I think that's good. Did you, Sharon, do the panelists, they all like to put their cameras on so we can see you all? Sharon, did you have any comments about PIMS at all? Did I say that right? Or you're on mute, I think, Sharon.
Thank you for mentioning the PIMS TS, and I note that I was meant to mention that in our talk, but honestly, we haven't seen it yet. Like the people in Sydney who have had, I think, in excess of, must be close to 5,000 patients through their books, have had one or possibly two cases of PIMS TS, and I think essentially there's two big points in relation to that. One is that the actual COVID that a person might have had could have been subclinical or extremely mild, and then they may present very, very unwell with multi-organ failure and a Kawasaki-like disease presentation. And you may not actually have they may have never been diagnosed with COVID. So I suppose there's that sort of index of suspicion when somebody presents with a Kawasaki-like presentation to think, could this be PIMS TS, even though there isn't a definite prior diagnosis of COVID. And yeah, and the other thing is that it's incredibly rare, but probably like most things, there's probably a spectrum of disease, and the incredibly rare bit is the extremely severe end of it, and there's probably a sort of a spectrum back to sort of, you know, sort of mild, sort of, you know, vesicles and a bit of a rash and a fever, and that may well be the other, that may be PIMS TS too. So I think we don't really know yet what that's going to look like, but we did get it sort of put a bit front and center in the health pathway because it is the feared complication. I suppose the other thing is, which may present after vaccinations, as well as the sort of myocarditis type picture. So yeah, so that's what all I want to say about PIMS TS.
And if I could just jump in, Joe, the Health Pathways team and with Joe and some cardiologists are developing a myocarditis pericarditis following mRNA vaccine pathway, which we're hoping to have live fairly soon.
Fingers crossed. Did you want to talk more about vaccination after infection, Michelle, to clarify around that?
I think that was okay. So that was the delayed schedule when you've already had one. The other part, of course, is if you haven't been vaccinated at all and you have COVID, then there isn't any urgency to vaccinate you because we think that natural immunity will protect you for a period of time up to about 6 months. So it's not that it's contraindicated. So there seem to be a few questions kicking around about that. And I keep seeing things about, oh, do I have to test that antibodies? And please don't do that. There is no current indication, I think, for doing any of that stuff. So that's a question that seems to come up in lots of places all the time. And the answer at the moment is no, don't do it. So yeah, so they can be vaccinated after, after about 6 months. Well, they have to have been fully recovered, but there's no urgency.
Can I just say, no, I guess the clearance information gives them 6 months, get out of jail free. So for work, whatever that requires vaccination or testing, they've got 6 months. So what I tell people is, you need to have your vaccination before that 6 months is up, because otherwise you'll run out of the end of it, and suddenly you might find that you can't turn up for work.
And
So
there would be
there's
no
no
problem
hurry.
with them coming in at 3 months, 3 months after recovery and being vaccinated, that'd be fine. I think a lot of this stuff was sort of written when we had a big shortage, and these were the people that needed the vaccination protection least in the immediate future. So as that is resolving, I think that's part of why it seems to have evolved a bit.
Got quite a few questions here. So one of them is from Marie Puxty up in Armdale, I believe, who would just like to clarify about country patients and their escalation plans. I know we've touched on it a bit, but it's probably worth going through a bit. And again, Mark, can you talk about how that would happen for them regionally?
Yes, look, that is in part a work in progress, and it also depends on the area. But we had, for example, in Armidale, we contacted the cases on a daily basis that were on our pathway, and we contacted the local health service and had advice as to who to escalate to. In fact, in Armidale, the community nursing service came out. They did an in-person assessment, and they dropped off the pulse oximeter, which was then used subsequently. And so the first set of people in Armidale, I think, worked quite well. Look, the times we've run into trouble are people who've moved from one area to another, and so we had somebody in Gunnedah, and then they were moved to Tamworth, and we didn't realise they were moved for a little while until we tracked them down. But so each time there's a new area, we firstly would try and make sure that people were close enough to a hospital that we could have an escalation pathway, and I would then speak to, or maybe one of our GPs will in future, speak to someone in the local area to have an escalation pathway locally. And there's also the potential for people to come here. So we've had people in our COVID hotel from much further out west, simply because they lived a long way away from medical attention. Can I quickly say I realised that we didn't acknowledge Eliza Milliken, who was a sort of advanced training infectious disease extraordinaire, who actually did a lot of work right from the start, including in last year. So in fact, a lot of the assessments tools were actually written last year, and they were just updated. And Eliza's been heavily involved, but now she's taken a job she needs for her training in microbiology. But she's, I think Joe and Lee have found her really helpful. She still is. I just realised we didn't mention her.
Great, thank you. Got a few questions from Simone just around the assessment process. So there's there's the patients that get sent to hospital and they'll be physically assessed. Then there's the patients that stay at home and their care is virtual, so that's via telephone. So no in-person assessment unless that's required. So unless they need to have their care escalated to either ED or to straight to the ward, it's the plan. Hopefully that clears that one up, Simone. And by far the majority of people are very well. They've got mild symptoms that are managed with Panadol and Nurofen and that sort of thing. Is that a fair call, Mark and Kathy and Sharon?
Yeah, quite a few people I think feel quite bad during the feel bad, but it's a matter of subjective of what the doctor thinks as well, what the patient thinks as well might be somewhat different. But yes, you probably agree with that, Kelly. I don't know.
Yeah, and we would agree too. But I mean, for us, we're trying as much as we can to avoid the emergency department. Our paediatric ED colleagues do not want us having patients going through ED. So our processes are around trying to discriminate between those patients that need admission, and we'd have a relatively low threshold for admitting kids if they were unwell versus the ones that can be managed with video conferencing and up to twice daily contact. But yeah, the kids that need admission, and our colleagues in Sydney have said the same, are people that have dehydration from diarrhea, for example, yeah, it's more a sort of dehydration sort of presentation rather than sort of respiratory symptoms. But the older adolescents do present with that sort of, some can have the sort of COVID pneumonitis type presentation, but the younger kids, it's really more oral intake problems that is the problem. So yeah.
I think with the planning for GPs in terms of looking after patients at home, I think it's you know, like how quickly people can deteriorate, and you know, if your experience is that it's not been too bad, it's been easy to pick up, that sort of thing. I mean, I haven't been with the team long enough to have a real comment on that, but Mark, is it something that you've observed, or a bit too early for the whole team really?
I think so. Look, if it does, on the whole, there does seem to be a different window. On the published material, it's probably 2.5 days between somebody becoming short of breath and needing some sort of respiratory support, which is the reason why during the intense period we do like to speak to people every day. And of course they have the pulse oximeters at home, they can use them at any time.
So switching topics a little bit, Margaret Lynch has a question about the day 20 de-isolation, Mark, and the definition of who's significantly immunocompromised that you might not actually de-isolate them.
Yeah, look, if you look at, so the song, Series of National Guidelines, everyone calls the song, they don't give a definition, but they give examples, and the examples are really immunosuppressed, like bone marrow transplant. So there's no, so a course of steroids for asthma, that doesn't count at all. And in fact, having had whatever tocilizumab or baricitinib for your COVID also doesn't count. It has to be a really serious immune deficiency or immune suppression. And I think I would say they're the ones, firstly, who we would have a very low threshold to admit to hospital, or just admit them straight off. A bone marrow transplant patient, we just tell them to go straight to hospital. And I feel, they're the ones to go to the infectious disease doctors or to have that decision made. And in fact, our simplified checklist basically doesn't include those people. They're to be referred to the doctor to work out, and they're people who basically you wouldn't expect them to have survived at home to be getting to the end of that 20 days in the first place.
They're going to be in hospital, probably. I've got a question about the sotrivimab from Ben Ewald, who's he's saying it's for people who have had 1 dose of vaccine or less than 2 weeks after second dose. That's different to the definition that we're using locally, Mark, for those that may be eligible. Is that right?
Yeah, look, that is the rule. I mean, sotrivimab is so monoclonal antibody. We have very limited supply for the whole of the north of the state, and it's, even though we're just actually talking about budesonide and sotrivimab, and you looking at them on paper, you might think that they're for similar groups of people, but actually that's certainly not our thinking. Our thinking is that sotrivimab is for people who are really immunosuppressed, basically, and it is to give them antibodies when they don't have antibodies, and it is a monoclonal antibody. It needs an infusion. Have to go somewhere that can give an infusion, and it has to be somewhere that someone who's COVID positive can get an infusion. So yeah, so we would feel, and one of our criteria is that they speak to one of the infectious disease doctors before giving it. We would feel that that is going to be given to somebody who has a serious problem with their immune system, even though in theory lots of people can tick 1 or 2 of those boxes. So that's my theory.
We had an pediatric infectious diseases talking to us about this yesterday, and they were saying that down in Sydney, because of the prevalence of obesity in their patient group, that they would need 2 significant risk factors, not just obesity. It would have to be obesity and cardiac disease, obesity and severe immunodeficiency. So the sort of common run-of-the-mill sort of comorbidities wouldn't be enough down in Sydney to get you across the line in terms of, I mean, again, it's a scarcity sort of decision making, because I think there's like 2,000 doses for the state, and we've already used 660 or something of them. So, like, if it was very available, probably people would be, a bit freer in terms of the criteria.
If it was a tablet, you just give it as well. And so I think when we gave it to a pregnant woman, and we gave it to pulmonary hypertension, so people with that's another pregnancy is another story, but that's people with more than obesity. Yeah.
Cool, thank you. Got another question for you, Mark, about the inhaled corticosteroids for the mild group.
So, really a benefit to so people who don't require supplemental oxygen, and that's the principal study, and they are either over 60 or over 50 with a risk factor, is that what it is? And the dose, a big dose, is 800 micrograms BD. It's enough to give you significant side effects, and the benefit overall is on the amount of from the principal study was the amount of supplemental oxygen required in hospital. So I think that's reasonable. It's definitely not for everyone. There's a more recent study on cyclizumide that gave it to everybody, and overall, despite how it's been presented, overall there was absolutely no difference between placebo and cyclizumide in their primary endpoint for that study. So we would say it's probably a good idea for people who would have met the principal criteria. If you're giving enough to cause side effects, that's causing a person a problem because it's a big dose, then I'd stop it. But at the moment, it does not appear to be for everybody. But I mean, you know, compared to Sotrovimab, it's easy. And looking at the national guidelines, they have it as a consider, not as a recommendation.
Watch this space. Cool. Thanks, Mark.
Yeah, I just spoke to Josh, Professor Davis, beforehand because he was quoting the paper. I just wanted to make sure I said the same thing as him, and that was his feeling as well.
Good. So we have a few GPs sort of making that inquiry again about the potential for being able to, for patients to be able to access Medicare rebates while they're inpatients, and how we might be able to escalate it to see if we can get that sorted out. Look, I think I feel like it's really well understood amongst all of the people here on this panel, and feel like we've been heard at every level that we can be heard at. So whether it's possible is just a matter of hoping that the right people can make that switch. I don't pretend to understand how it works or at what point that decision's made and all of that sort of stuff, but it's certainly happening in other health regions. So fingers crossed it can happen for us as well. Unless, does anyone else want to comment on that, or am I in line? It's about as much as we can say, I think.
I think I think until that's resolved, there is no shared care, there is no integration of care because we're hamstrung as GPs.
Yeah, which builds onto there's several questions actually talking about capacity, and I'm not sure how to answer this one. I know it's a tough one for all of the people here. Yeah, is there a sense at which it would be very difficult to manage the numbers of cases that are coming through, at like where we would you know, really need to urgently maybe start discharging patients straight to general practice rather than coming through the community care teams?
Look, I feel that, well, you know, we are already pretty close to capacity, aren't we? And numbers are keeping on coming in. So the question is what we're going to do there. So watch the space. That would be what I'd say.
So as a GP in the community, like Michelle, what would your, you know, understanding that, what would you be thinking about in terms of preparing?
Well, so I think it's difficult, isn't it? Because I think what we're facing locally is the prospect that the system will become overwhelmed, and the first sight that we will get as GPs that the system is overwhelmed is when it's on our doorstep. So it becomes our problem without any kind of warning. So, and I think that's probably what the concern in the GP community is, or from what I'm hearing. And it's not really anything that any of us people here have the power to solve, but I think that is the reality. So as a practice, we're gearing up, we're getting ready we can do telehealth, we can do, you know, we know we can use e-scripts, we are still vaccinating everybody that we can possibly vaccinate. You know, so we're getting autofills ready. We are, you know, we've got the pathway now, so that helps hugely to be familiar with those resources. You know, be familiar with the RACGP guidelines. Just so I think that personally, I want to be ready for that happening, and I don't mind doing the work now to save a whole load of misery if it does come crashing down. It might not come crashing down, and I would be very happy if it doesn't come crashing down, and the capacity meets the demand. But my concern is that this is an unpredictable and extremely infectious disease. So I think the other thing that GPs should really be doing is working out what they do when they get the COVID case come through. And if you haven't done that already, please do it. I know I'm boring on this, and I have banged on about it repeatedly everywhere that I go. But, you know, you will get somebody with COVID in your waiting room soon. You know, it's going to happen. So you need to know what to do, how that's going to affect you, whether you're going to have close contacts amongst your staff, whether you can still run your service, whether you can still keep vaccinating, etc. And that's going to depend on a lot of things, but largely on your PPE and your physical controls. So also get set up to work at home if you possibly can, so you can still do stuff. Sorry, that's just my banging on about the same old things.
Joe, can I just jump in? We also, the other thing we did this week was we bolstered up the practice management health pathway, and we added a section on what to do, you know, to plan for positive patients in both your general practice team and in the surgery. And so we've added a few more things in there that you might find useful for that sort of planning.
Joe, can I just add to that conversation? Sorry, two things. One small thing about PPE, and we have had cause to look at this very closely in the last few days, is that protective eyewear is a critical part of your PPE, and if you are not wearing your protective eyewear, then your level of risk when you encounter the unexpected COVID positive patient is significantly higher. So in any clinical setting, just to reiterate that the protective eyewear is massively important. So that was
Thank you, Sharon. Can I just jump in on that? Because I have been banging on about this for some time. And the other part of it is that just your normal spectacles doesn't count. So can we just be completely clear? We're talking about safety goggles, safety glasses, prescription safety glasses, or a shield. Like, I love that everyone's got them. Some people are at home, they've still got their protective eyewear.
Mine are just out of reach, but they're just over there.
Thank you.
I feel
and look,
like
the
I'm
other
the
thing
only pharmacist that's wearing them.
Yeah, good for you. And look, the other thing was actually just to back to the conversation around models of care for GPs to be able to be involved in this surge. And we don't have a lot of details about it because our colleagues in Sydney were a little bit cagey, but our paediatric colleagues in Sydney have set up a trial with a large group practice in Western Sydney, where the group practices agreed to take patients that aren't their own patients who have been identified as low risk. So the problem for us is the fragmentation of care and the fact that the vast majority of the patients that are coming through don't have a GP that they have a relationship with, and the fact that there has to be a sort of level of multidisciplinary care for the patients, and also enough staffing that the people can be followed up 7 days a week. So this model of, it's sort of almost like a GP access sort of model where you have a community of GPs who are saying, like, we will provide this service. And I think if we were to have something like that locally, I think our concerns around, like, you know, that people wouldn't sort of, that individual GPs might then not be able to, you know, they might not be there, and then nobody gets seen, and then, you know, and obviously the Ministry of Health is on our case around this because of people being dead at home, and so that we really need to be providing the level of care that is seen to be what is expected for COVID. I mean, and it may change, and we were talking yesterday about the potential of two pathways of people who are vaccinated with COVID versus people who are not vaccinated with COVID. But this model that our Sydney colleagues are working on might work here, but it won't. Like, if every GP in the whole district takes maybe one COVID patient when they're the ones that are on their books, I don't think it will work. So maybe there's some other, you know, and you're all like, there's lots of people on this. So I'm sure there is, you know, potential for looking at some sort of collaborative space to offer that sort of low risk pathway. I haven't talked to Mark about this, and we're really just sort of spitballing, but yeah, maybe that's the way forward.
I feel that I'm just very happy we've got GPs working with us now, because we've got that interaction. I mean, that's always the issue of the hospital doctors and the community doctors, and so the fact we've got them together in the same place, hopefully we can get it working for COVID, and hopefully that continues afterwards.
Yeah, that's right. There's some short-term pain, but there'll hopefully be lots of long-term gain as well. There's a few questions here around those deaths at home. Is there any, is there much in the way of understanding the circumstances around them that you guys have had access to and understand around those ones that have been happening in Sydney?
Look, I know about the one death that we had, I don't feel at liberty to talk. It was a tragic case, and it was recognised the patient was deteriorating. But in due course, that will be a coroner's case, and it will all become clearer then, I hope.
The ones in Sydney, a lot of the deaths haven't been actually picked up. Is that right? Though they've been, you know, maybe
These
not
are usually,
under care at all.
Families that didn't want to present with COVID because they may have been the only breadwinner and they didn't want to sort of present forward. So that's my understanding of certainly multicultural families and big families, and the stigma of having COVID and not wanting to move forward and test positive for COVID, which is really sad.
Yeah. So unmonitored sometimes as well, which is tragic.
They were never on the HIF service.
Never even picked up. Yeah.
And then I think our Sydney colleagues also had some where there was an entire family, but they went to do a home visit on the kids, and you know have found parents in extremis and you know unable to get to the phone to to call an ambulance. So
they're very, very strong on teaching anyone over 8 how to call an ambulance.
Wow.
So they're very, very clear on all of their phone calls to train the kids how to access phones and call ambulances.
Right, good. Well, you know, I think we've actually covered, there's some questions around vaccinations that I'm not quite sure if we've got the expertise here, but does anyone know the current vaccination rate for our Indigenous population locally in Hunter, New England? I haven't got those details to hand.
Yeah, my working thing in my head is about 20 percentage points below non-Indigenous, but I'm not sure of the exact figure.
It's still some work to be done. You know, I think we've actually covered most of the themes. There's some good ideas here about trying to get shared models of care. I think we need to get some discussions going in base camp and that sort of thing, just to keep the juices flowing. Wonderful. All right. I think, Michelle, were there any other questions that you wanted to put to the crowd here? I feel like we've covered most of the ones that you gave me to prepare.
No, I don't think so. I didn't know if team had access to the MHR. Do they? That was just.
They do. So yeah, so we can access. There's like a little tab in the clinical software. I should get to know their names a little better. But it was actually very helpful. The other day I had the fellow with a headache that wanted to restart his antihypertensive medication that he probably hadn't had for about 6 months, I'm pretty sure. I was able to check in the MyHR and see where what his last dose and dispense was. So it was good. Very helpful.
Okay, but if GPs are actually uploading a reasonable, up-to-date, beautiful summary, that might be some way that you could contribute to the care of your patients.
Absolutely, actually, that's a really good thought, Michelle.
With pretty much just one click, not too hard.
Yep,
yeah,
a nice recent. Yep.
Okay.
Instead of bloods or something, that would be helpful. Yeah.
That could be something we could put in the pathway. Ensure their health record is up to date.
Yeah, we talked a lot about that with
and get your PIP at the same time.
Oh, nice. You're incentivized. Yeah, we talked about how important that was with aged care facilities in terms of preparing for an outbreak within them, and really it's the same for our entire community now. Yeah, because we're all going to catch this at some point, aren't we?
And I guess increasingly what we're expecting is that it's going to be, a disease of the unvaccinated, so the under 12s and the unvaccinated adults. So I suppose that's, that's what we're going to be, that's what I'm expecting that we're going to be seeing.
Yeah, which is going to be less of our GP cohort,
Yeah.
Of all, the patients that I've been seeing, most of them are getting vaccinated. There's not that many of them. You know what I mean? Like I think the unvaccinated cohort really aren't the ones that are connected well with their general practitioners. Anyway, wonderful. Look, I think that's our questions for this evening. Thank you very much, panelists. That was fabulous. Jenny.
Thank you, everyone. And Joe, you've done a wonderful job with the questions. And Michelle, thank you as well, and our hospital doctors. It's it's a great relief to know that we're in such good hands during this crazy time that we're in. This has been recorded, this webinar, and will be up on the PHN website in the Education Library. At the end, there will be a very quick evaluation. We would love your feedback. And there's a place there that you can put in any topics that you would like. So please fill it in because we definitely do respond to requests that we get. All right, well, thanks again, everybody, and keep safe.
Thank you, everyone.
Thank you.